Modern critical care utilizes mechanical ventilation to sustain lungs and continuous infusions to stabilize failing hearts. This high-tech intervention prevents immediate mortality, yet the transition from hospital to home remains clinically precarious. Over the last decade, we have gotten incredibly good at that initial stabilization. This chart tracks physiological survival rates in intensive care units, and the trend is clear. More people are surviving the acute phase of illness than ever before. Yet, if we track those same patients 12 to 24 months later, a second trend emerges. Health-related quality of life and rates of returning to work drop significantly during that same window. Physiological survival frequently occurs without a corresponding return to functional recovery. Clinicians recognize this phenomenon as post-intensive care syndrome, or PICS. PICS describes a multi-domain cluster of physical, cognitive, and psychological impairments that persist long after the acute hospitalization ends. The reason recovery often fails is rooted in how the medical system evaluates the patient, traditionally treating them as an isolated biological unit. To optimize long-term outcomes, critical care must reevaluate recovery as a reciprocal ecosystem involving the patient, the ICU environment, and the caregiver. We can map this ecosystem starting with the 3 internal domains of the patient. The first domain is physical dysfunction, specifically ICU-acquired weakness. Prolonged mechanical ventilation and the use of muscle relaxants are primary drivers of critical illness polyneuropathy and myopathy. The body's physical architecture begins to degrade while on life support. The statistical impact is significant. Data shows that of the patients who were living independently before their ICU admission, nearly half lose that independence 6 months after they are discharged. Physical decline is compounded by cognitive dysfunction. There is a direct clinical link between the duration of ICU delirium and the severity of long-term cognitive decline. The underlying cause is systemic inflammation. Critical illness triggers a response that damages the blood-brain barrier's endothelial cells. This damage allows for low-grade, persistent inflammation in the brain, leading to measurable white matter disruption. Standard life-saving interventions, such as deep sedation, can actually exacerbate these cognitive impairments by prolonging periods of brain dysfunction. The very interventions used to prevent acute mortality simultaneously contribute to a patient's long-term neurological and physical deficits. These deficits feed into the final patient domain, psychological dysfunction. ICU-specific post-traumatic stress disorder is a distinct clinical entity, differing from traditional PTSD in its origin and progression. While traditional PTSD often stems from a single traumatic event, the ICU version results from continuous, prolonged exposure to trauma. Under deep sedation, the brain often fails to integrate sensory inputs. Patients register fragmented memories of pain, blaring medical alarms, and partial conversations. Because these memories are fragmented and poorly integrated, symptoms often manifest as a delayed onset worsening over the first 2 years of recovery. This psychological burden compounds the physical and cognitive impairments, frequently removing the motivation necessary for rehabilitation. Surviving the physiological crisis often leaves the patient trapped in a psychological one, making an isolation-based recovery model ineffective. The morbidity of critical illness extends beyond the hospital bed, impacting the entire household. To understand the system, we must include the caregiver ecosystem and the psychological distress known as PICS family. Over half of all patients requiring prolonged mechanical ventilation will need dedicated assistance from a caregiver 1 year after discharge. This reliance creates role strain. As the Mayo Clinic documentation highlights, factors like living with the patient and spending many hours on caregiving duties force a reorganization of family life. This constant demand frequently leads to psychological morbidity. Caregivers report high incidences of feeling helpless or depressed as the systemic stress of the household rises. A reciprocal loop forms. The patient's functional deficit increases caregiver stress, while caregiver burnout is directly correlated with worse long-term recovery for the patient. The two systems reinforce one another. A decline in one node accelerates the decline in the other. Treating the patient as an isolated unit is insufficient because the trauma of caregiving compromises the very home ecosystem required for their support. Mitigating PICS and PICS family cannot rely solely on outpatient clinics following discharge. Prevention requires the ABCDEFGH bundle, an active clinical framework applied while the patient is still in the ICU. The first 4 steps, A, B, C, and D, focus on assessing pain, promoting spontaneous breathing, optimizing sedation choice, and managing delirium. Minimizing deep sedation keeps the patient cognitively active. This protects cognitive integrity and prevents the fragmented memories that drive post-ICU PTSD. The next phase, Step E, mandates early mobility and physical exercise. Implementing physical therapy and neuromuscular electrical stimulation within 72 hours of admission combats the onset of ICU-acquired weakness. Steps F, G, and H integrate the family through engagement, good communication practices, and educational handouts. These communication steps are required clinical interventions designed to prevent the psychological onset of PICS family. Every element of the bundle acts as a countermeasure against the vulnerabilities of the patient-caregiver ecosystem. The ABCDEFGH bundle functions as an engineering framework for recovery. It allows clinicians to proactively mitigate long-term damage while the patient is still in the acute phase of treatment. While rising ICU survival rates prove our ability to prevent acute mortality, they do not account for the quality of life that follows. Without proactive mitigation integrated into daily ICU workflows, patients will continue to face years of chronic morbidity. The medical discipline requires an expanded definition of successful intensive care. Clinically successful outcomes require the preservation of systemic resilience in both the patient and their family. True long-term functional recovery is actively engineered from the first day of treatment in the intensive care unit.